Hello, everyone. I welcome you all on behalf of IASNM MISSI webinar series. The webinar is going to be around 45 minutes talk, followed by 10 to 15 minutes of Q&A session. A few housekeeping stuff. Please keep your mobile phones and devices on the mute. And you can put in your questions in the chat box, and we'll come to them at the end of the session. And now it's my absolute pleasure to introduce Dr. Anchal Ghai. She has completed her doctoral training in nuclear medicine from India in 2016. Her PhD work was focused on developing bioconjugation and radiolabeling techniques for nanoparticles to image tumor angiogenesis. During her postdoctoral training at WashU University in St. Louis, US, she developed antibody-based PET imaging agents to diagnose and stratify myeloma patients for targeted immunotherapy. Dr. Ghai has also been involved in the translation of a PET imaging agent, and that was evaluated in a first-in-human pilot imaging study in multiple myeloma patients at Washington University in St. Louis. Dr. Ghai has recently joined the Faculty of Biomedical Engineering at UT Southwestern Medical Center in Dallas in April 2022. She is currently leading a research project focused on exploring the potential of Cherenkov radiation produced by positron emitters in combination with chemotherapeutic drugs. That is primarily to treat hematologic malignancies. Dr. Ghai's primary area of expertise are in targeted molecular and nuclear imaging of cancer, designing new therapeutic strategies for hematologic and solid tumor malignancies, and translation of these novel basic science discoveries to clinical setup. Without further ado, Dr. Ghai.
Thank you, Saima, for the kind introduction and for giving me the opportunity to share my research with this group. Shall I share the screen?
Please go ahead and share your presentation.
All right, so I just put it in the... So as Saima mentioned, my previous research was mostly focused on developing PET imaging agents for hematological malignancies like multiple myeloma. And the current projects are taking a step forward in developing novel, efficient therapies for treating myeloma. So I'll just give a brief introduction. We all know what multiple myeloma is, but I'll just give a brief introduction about it. Multiple myeloma is a clonal plasma cell malignancy, which is characterized by abnormal proliferation of plasma cells in the bone marrow. And today I'll be discussing about the preclinical imaging agents I've developed for myeloma at WashU. So I was working at Washington University in St. Louis for my as a postdoc, and then before I moved to UT Southwestern 2 years ago. So I'll talk about the imaging agents which we develop for early diagnosis, staging, and timely determination of therapeutic response. Then my experience with filing an EIND with FDA for a PET imaging agent for myeloma. And then my current experience with the novel therapeutic strategies for myeloma in combination with conventional therapies. So most of my research is based on receptor targeted molecular imaging. But what is receptor targeted molecular imaging? We usually identify a receptor that's readily available on our cells of interest. I then identify a ligand or vector that binds specifically to the target. And the idea is to tag this ligand with either a radionuclide of interest or an optical dye, and then image it when it binds to the receptor in vivo. So we have been using these PET radionuclides because PET imaging has been utilized for assessing biological processes at cellular and molecular level. And also PET-CT facilitates longitudinal sensitive detection of myeloma-induced bone lesions and extramedullary disease. So, I mean, this group doesn't need introduction of what FDG is. I'll just quickly walk you through what I'm trying to say here. That the field of hematological malignancy, of hematological imaging, has been dominated by F18 FDG to a very good extent, to a good effect, rather. And FDG, but despite being the gold standard for myeloma imaging, it still has certain limitations. For example, FDG is unable to distinguish between the malignant cells and the inflammation following therapy, leading to false positive results. And also in metabolically low myeloma lesions, it invariably results in underestimation of tumor burden. To overcome these limitations, a more specific and sensitive PET imaging agent is desirable in myeloma patients. And molecular imaging of specific receptors overexpressed on tumor cells is the key to realizing the concept of precision health. So there are many approved conventional therapies for myeloma that include proteasome inhibitors, kinase inhibitors, cell cycle inhibitors, and antibodies for immunotherapy. So current treatments, they have improved the survival rate. However, the myeloma patients, they relapse. So prognostic classification of these patients solely based on genetics can be challenging at the time of diagnosis. So therefore, monitoring the therapeutic response is considered an important approach to identify the patients who are progressing quicker and who need to be monitored closely. So imaging-based timely determination of therapeutic response is critical for improving the outcomes. I'll be focusing on the receptor-targeted imaging. I'll be talking about two receptors, the CD38 and CS1, which, I've worked on these two. So first of all, talking about CD38, which is expressed on terminally differentiated myeloma cells, as well as on the cell surface of other lymphoid tumors. So daratumumab, which is the monoclonal FDA-approved antibody, it targets CD38 and is used as a frontline therapy for myeloma. Antibodies, have evolved as reliable vehicles for the delivery of radionuclides and drugs to cancer cells due to their high selectivity and affinity. And long-lived radioisotopes like zirconium-89 with a half-life of 3.3 days approximately. It matches the pharmacokinetics of antibody. Therefore, we radiolabeled daratumumab with zirconium-89. And we hypothesized in this project that the enhanced CD38 expression on the cell surface of myeloma cells will favor increased zirconium dara uptake allowing impactful PET imaging for therapeutic planning as a companion diagnostic. And we used the human multiple myeloma cell lines, MM1S, therefore expressing luciferase, and injected them in immune-compromised mice. So this is just a brief description of what we did. We conjugated daratumumab with a bifunctional chelator DFO, and then DFO was labeled with zirconium-89, and this radiotracer was further used to in different in vitro and in vivo studies. Here, we saw that daratumumab DFO, it was radio-labeled with a high radiochemical purity. More than 99% was obtained after the label conjugate was purified. In vitro serum stability tests here demonstrated that the radio-labeled antibody was stable with more than 98% intact radioactivity for up to 7 days. This is just one slide to give you an idea on the type of preclinical studies we performed before the actual preclinical PET imaging. So we did flow cytometry on the MM1S cells we used for CD38 expression, and we see that most of them are expressing CD38. We also did the saturation binding curve with the radiotracer, and it's a radioligand saturation binding assay is a sensitive method for quantifying the ligand receptor binding parameters. The data here demonstrated that in a wide concentration range between 0.25 to 16 nanomolar, zirconium dara is bound to a single class of binding sites. We also did a whole cell uptake for the radiotracer in MM1S cells in the presence and absence of a blocking agent. And we see that in the presence of a blocking agent, the uptake was significantly reduced. We developed an optical analog of DARA-DFO by tagging it with Psi5, and binding of DARA-Psi5 was evaluated using confocal microscopy, and MM1S cells were treated with DARA-Psi5 and in the presence and absence, and we can see that in the presence we see a beautiful signal on the cell surface, and the signal is from DARA-Psi5, whereas in the presence of a block, the signal is significantly reduced. So the MM1S solid and the subQ disseminated tumors were developed in immune deficient mice, and tumor progression was monitored weekly by BLI. So this slide shows the MIP images of the mice bearing subcutaneous MM1S tumors. And the data showed appropriate sensitivity and selectivity if you can appreciate the different sizes and volumes of the tumor. Even as it was able to detect even the small non-palpable tumors. It's that sensitive. So the region of interest analysis was done, and the SUVs were ranged from 2.1 to 9.3 in varying tumor sizes and volumes. So on the right-hand side, we see the PET-CT images in a disseminated tumor-bearing mice. The cells were injected intravenously, so the tumor is in the bone marrow-rich skeletal sites, spine, pelvis, and the leg bones. And this data showed that significant radiotracer uptake was present in these marrow-rich skeletal sites. We also did an in vivo blocking study, which was conducted with 200-fold molar excess of cold daratumumab, which was injected via tailwind 15 minutes before the injection of the actual radiotracer. And here we can see this was supposed to be the tumor up, showing up if it was not, if it was without the block, the cold daratumumab. And the radiotracer uptake was significantly reduced in the presence of the block. The autoradiographic slices here from the excised tumors are in correlation with the PET-CT imaging data. So in this project, our preclinical data suggested that DARA radiolabeled with zirconium-89, it's a promising immune PET radiopharmaceutical that can be used for non-invasive imaging of CD38 positive myeloma tumors. So we studied another target on myeloma cells, which is CS1, which is a glycoprotein. It's again overexpressed in myeloma cells, and elotuzumab is the monoclonal antibody that targets CS1. Again, it's approved in myeloma patients. It's used in combination with lenalidomide and dexamethasone. The goal was similar. The goal of the study was similar to our previous study, to develop and validate elotuzumab-based imaging agents that could help stratify patients for combinational elotuzumab therapy. We used the same cell lines, and most of the studies done were similar, except that we did a comparative study between zirconium, elotuzumab, and FDG on the same group of tumors, tumor-bearing mice. And we saw that the BLI signal, so this is just the BLI signal to show the presence of tumors. These are the FDG images, and these are zirconium elotuzumab images. And the analysis showed significantly higher uptake in tumor-bearing tissues in mice imaged with zirconium elotuzumab as compared to those imaged with F18 FDG. So to further demonstrate the specificity of zirconium elotuzumab for CS1, we did another in vivo docking study. In the same mouse model, BLI of these mice confirmed the presence of lesions, the skeletal lesions, and the zirconium elo uptake in the bone marrow-rich regions. In the presence of excess, the uptake was reduced in the presence of the blob. So, this gave us an idea of how specific this is. So again, we demonstrated the zirconium elotuzumab mimicked the behavior of naive elotuzumab drug we used as an immunoPET biomarker to evaluate therapy responses. So after the antibodies, we moved to the small molecules for imaging myeloma. Another very important target in myeloma is the VLA4, which is a non-covalent heterodimeric integrin receptor. It's upregulated in multiple myeloma. We and others have shown the efficacy of a VLA4 targeted radiotracer, copper 64 LLP2A, in several pathologies, including myeloma, melanoma, and inflammation. So VLA4 helps in regulating signal transduction pathways that include cell adhesion, migration, apoptosis, proliferation, and so on. It plays a crucial role in drug resistance in hematological malignancies like myeloma and leukemia. So we know that integrins, they have the ability to induce bidirectional signaling, that is inside out and outside in signaling. So here the different VLA4 is usually in the inactive state. It's activated by conformational change within the cell, the inside out signaling, and then the activated receptor triggers high affinity for the ligand binding, resulting in the activation of outside in signaling. So that's how it works. The underlying hypothesis of this project was that molecular imaging of VLA4 combined with the metabolic status can provide promising synergistic information on disease progression and therapeutic response. In this study, we compared the efficacy of F18FDG with copper LLP2A PET tracer for quantitative longitudinal imaging of disease progression and bortezomib therapy response in disseminated models of preclinical models of human myeloma. We used two different cell lines which were showing different variable expression of VLA4, again in immune compromised mice. So this is the study design, which I'll just walk you through. NSG mice were injected with human myeloma cell lines MM1S or U266. So MM1S, for the record, they have low VLA4 expression, and U266 cells, they have high VLA4 expression. And tumor progression was monitored by weekly BLI. Mice were divided into 3 cohorts: untreated, which were tumor-bearing but untreated, and tumor-bearing treated with bortezomib, and there were healthy controls with no tumors. Once the total body flux from each mouse in the treated and untreated reached to a certain value, which is e to the power 6. The longitudinal PET imaging was initiated, followed by bortezomib therapy. So the baseline was week 0, where there was no therapy. And after that, the bortezomib therapy was started, and they were imaged weekly by PET as well as BLI. And the treatment group that was injected with bortezomib, 1 milligram per kg body weight twice a week intraperitoneally. This was the treatment regimen. Untreated tumor-bearing mice, they died due to disease-related complications, or they were euthanized at the onset of paralysis. So this slide shows the therapy response evaluation by BLI in both MM1S and U266 cells. Small animal BLI, it was crucial for validating the establishment of disseminated disease and for the therapy response. They confirmed here, BLI images at week 0, they confirmed the presence of tumor in the bone marrow rich sites, and they showed increased whole body luciferase activity in the untreated compared to the treated ones. And we can appreciate that at week 0, the tumor signal in all the mice, this is just a representative image, it was comparable, it was similar in all of these. And then with time, the untreated showed increased BLI signal that confirms high tumor signal as compared to the treated groups in both MM1S and U266. So this is a busy slide, I know, and my apologies for that, but this was important. So mice from all the cohorts, the non-tumor bearing control, MM1S and U266 myeloma tumor bearing mice treated and untreated. They were imaged with FDG and copper LLP2A weekly from week 0 to 5. The radiotracer uptake was quantified longitudinally using the SUV in different organs. We did spine, right femur, left femur. In MM1S mice, this is with MM1S tumor model. The FDG showed normal physiological uptake in metabolically active organs and some background uptake in the leg muscles and the brown fat. The copper LLP2A PET showed robust uptake of radiotracer in tumor-rich skeletal sites. I don't thank you, but here, so in the leg bones and in the spine, you can probably appreciate the punctate signals with copper LLP2A. So the SUV data at the pre-therapy here at week 0 showed no significant differences in the spine, right femur and left femur among the tumor bearing. This was the baseline. Figure C in comparison shows the comparison of percent change in SUV among different cohorts with both FDG and copper LLP2A tracer. We can see that in F18 FDG imaging, it showed threefold increase in the spine uptake in untreated mice as compared to the mice treated with bortezomib. But in case of right and the left femur, there is no significant difference seen with F18 FDG, whereas in case of copper LLP2A, you can appreciate the difference as early as week 2 in the spine, and you do see a significant difference in the uptake in the tumor progression of untreated and treated in the femurs at week 4. So similarly in this slide, it's the U266 tumor model. The results were similar. Figure A here shows the MIP images of FDG, normal physiological uptake, not much to differentiate. And in copper LLP2A, we do see some punctate signals of the lesions. The SUV quantification at week 0 is not significant amongst different groups. But here we can see that the SUV uptake in FDG for the spine it's quite prominent here at week 3. And for copper LLP2A, we can see it's quite prominent starting week 2. So this study demonstrated significant qualitative and quantitative differences in the uptake of FDG and copper LLP2A tracers in preclinical models of myeloma. And this tracer was translated into clinic. And I'll just quickly shifted gears to the translational. So copper 64 LLP2A was translated into clinic. We filed an EIND on the basis of the preclinical data, and a lot of work has already been done. I did not have the bandwidth to show all of that, but just some important points I'd like to make here. So one of the overt features of myeloma is the presentation of diffuse infiltration and punctate focal lesions in the bone marrow. Molecular PET and functional MR are highly informative in the management of patients with myeloma, from initial diagnosis to therapy and longitudinal tumor monitoring. So based on the qualitative analysis, we'll decide. So this is the image. We had some normal volunteers for this EIND and some myeloma patients. And this image just, we tried to image them at different time points between 1 to 5 hour post injection of the radiotracer. The images were, still better as compared to the ones which were taken typically around 24 hours. So this helped us. The best quality images were obtained between 1 to 5. So this study, initial imaging study, helped us determine the best time points. So 2 participants had a new diagnosis of myeloma. Both had negative FDG PET-CT for diffuse or focal areas of increased uptake. However, one of these participants had a lytic non-FDG avid lesion in the right iliac bone, which demonstrated. So here, just to explain it a little bit, if you look at the arrows, there is no FDG signal, but in the same patient, if we do see the copper LLP2A scan, we do see a very focally intense uptake of the radiotracer. And the SUV for this was 29.5 compared to the SUV of FDG, which was 2.9. So this was the star image. And the metabolite and toxicity studies were also done with this radiotracer, but I have not shown the data. This is published data, and if you would like to go back and refer to that, So now I'll shift gears again from imaging to therapy. And this is the current project I'm working on. So the major obstacle hindering improved outcomes, it remains the heterogeneous nature of myeloma cells that lead to the development of resistance to cancer immunotherapies, resulting in variable patient responses. Innovative treatment paradigms such as radionuclide stimulated therapy, RAST, also known as Cherenkov radiation-induced therapy, involves the use of Cherenkov radiation for cancer treatment. And that could potentially help to overcome the challenges we are facing in treating multiple myeloma. So Cherenkov radiation, for a brief introduction, is the radiation produced by the interaction of charged particles with surrounding tissue during a radioactive decay. And it can act as a depth-independent excitation source for photosensitizer activation to generate reactive oxygen species. So, and reactive oxygen species, and it can lead to cell death using different mechanisms like apoptosis, necroptosis, and ferroptosis. In this project, we hypothesized that the combination of a chemotherapeutic drug like bortezomib, which is FDA approved in myeloma, treatment of myeloma, with RAST regimen, which is radionuclide stimulated therapy, will lead to synergistic therapeutic response with minimal off-target toxicity. In order to achieve the goal, we use zirconium daratumumab, which we know targets myeloma cells by targeting CD38 as the Cherenkov radiation source, and modify TiO2 nanoparticles with transferrin and titanosin as the photosensitizer. So this is the study design. Again, it's a busy one, and I'll try my best to walk you through this. MM1S Luke cells were used for the study. The subcutaneous tumor-bearing mice, they were divided into the subcutaneous. We did it in subcu and disseminated models both, and this is a study design that explains both. So there were different groups. There were tumor-bearing mice which were not treated. Tumor-bearing mice, all of them were tumor-bearing with nanoparticle treatment only, with zirconium daratumumab treatment only, with bortezomib treatment only. These were the control groups, and then there was the group which was injected. The mice were injected with zirconium dara followed by the nanoparticles, because that's the combination that's going to work. And then there was one more group in which we gave the bortezomib therapy in combination with the RAST. So the radiotracer was injected intravenously in appropriate cohorts at days 21 and 35. This was followed by, so here, the days 21 and 35, we did 2 therapies of RAST. This was followed by intravenous injection of nanoparticles at days 24, 3 days after the radiotracer injections, to let the radiotracer uptake happen. And then we injected the nanoparticles at day 24 and 38. The mice were monitored for any treatment response by weekly BLI. Again, the bortezomib regimen was same 1 milligram per kg intraperitoneally twice a week. And the therapy response was measured by BLI. So we observed, this is the RAS treatment in subcutaneous myeloma model. We observed that the BLI flux of tumors in RAS mice was significantly reduced. The green one is the RAS mice, and the BLI flux was significantly reduced as compared to other control groups. And it was reduced up to by day 38 post-inoculation of tumors, and no significant reduction of tumor size was obtained in other groups. Here, the in vivo PET imaging data at day 38 was in correlation with the BLI data, showing reduced radiotracer uptake. And we can see that the SUV was reduced pre-crit. It was 2.85. It was reduced to 1.9. However, there was a sudden increase in the BLI in the RAST group after day 40, and it confirmed the relapse of the disease. So the administration, it was very disappointing because the administration of nanoparticles in zirconium daratumumab alone fell short of long-term tumor regression. So we were thinking what to do. And then we decided that we might want to try to treat this group with bortezomib. So we started the bortezomib treatment at day 51, and we observed a slight decrease, but that was not significant. Therefore, the study was terminated. So to improve the efficacy of RAS tumor-bearing mice, we started another study, another group in which the tumor-bearing mice were given combinational therapy with bortezomib and RAS. So these mice, the one in the data in blue, they were given combinational therapy with bortezomib and RAS. The bortezomib treatment was started simultaneously here when the RAS was started, and the in vivo quantitative data showed no significant differences among the control groups here. The mice treated with bortezomib alone, that was another group we added, the bortezomib alone group, it showed comparatively less tumor burden than the untreated control group, but overall it demonstrated an increasing trend here, the one in black. So the chemo RAS, so the group where we started bortezomib and RAS simultaneously, we call it the chemo RAS group. And the chemo RAS group started showing decreasing BLI trend. That means there was less tumor signal coming from these mice, and it continued to decrease significantly over a period of time. We evaluated the therapy response of chemo RAS in a disseminated human myeloma mouse model, again with BLI. The qualitative BLI images here, they confirm the presence of comparable tumor burden. Pre-therapy, they were almost all similar in all the groups. And then the comparison of in vivo BLI data here post-therapy showed increased luciferin activity, which is increased tumor progression in other control groups. The quality and the mice treated with RAS, they responded initially to therapy, but then they relapsed. So there is some signal here. However, the mice treated with RAS in combination with bortezomib showed different responses. They showed partial and complete response. I wish I had used a different color to differentiate the two, but the dark green one is the partial responder and the light green is the complete responder. So the partial responders, they had low tumor burden compared to other control groups, but they had an increasing trend. Whereas the one with complete response to chemoras, the group with complete response to chemoras, they showed significantly low luciferin activity as compared to other treatment groups. We did a survival study, and we observed that the mice treated with chemoras, they had 60% survival rate, while the study was terminated at day 140, and with 100% survival rate for complete responders. So for our future studies, this is very exciting, and we are going to take it forward with different radionuclides, different tumor models, and we do plan on looking at the mechanistic approach of the cell death with RAST and the combination therapy, because you got to know the mechanism that's killing the tumor cells. So yeah, that being said, we are hoping and looking forward to collaborate with clinicians which are interested in looking at the myeloma, cohort of patients and making an impact in the field of multiple myeloma. So with that being said, I'd like to thank all the colleagues and my mentors at WashU and UD Southwestern, Dr. Monica Shokeen. I've been working with her in all the EIND, the clinical translational stuff I did with her. She's amazing. And at UD Southwestern, my mentor, Dr. Samuel Lechilev, who I'm working with him on the therapeutic side of multiple myeloma. So I'd like to thank them all. And with this, I think I'm ready to take any questions you have.
Thank you very much, Anchal. Very interesting talk and very good insight into what's in the pipeline and what work is going on in the field of multiple myeloma and hematologic malignancies. I'll start with the first question that I have in the chat by Subhash. And the question is, how are we using Chernobyl radiation in PET-CT imaging?
So we are not using Cherenkov for PET imaging. We are using it as a Cherenkov radiation source, which is being used to excite the photosensitizers for creating reactive oxygen species. So we can actually image Cherenkov radiation as well. There are instruments which can image Cherenkov radiation, but we are in this project, we are not doing that. We're just using the Cherenkov radiation for therapy, for exciting the photosensitizers to create reactive oxygen species to kill the tumor cells.
Thank you. Is there any question? Otherwise, I can ask one of the...
I have a couple of questions, Emma. So great talk, Achal. Could you go to your slide showing the normal versus multiple myeloma patients?
Sure.
Yeah, that one.
This one?
Yeah, so the normal seems to be showing more splenic uptake and bone marrow uptake consistently over 60 to 40 and 24 minutes, whereas in the multiple myeloma patients, that seems to be slightly different. Any reasoning for that?
That's a very good observation. I don't have an answer to that. So VLA4, it is expressed in copper LP2A uptake. We do see it in the spleen. So even in the animal imaging, preclinical imaging, if we see it is expressed VLA4 in spleen, in some cells in the spleen, and we do see that uptake. But the reason why we don't see it in the multiple myeloma patients, that's a very good observation. I'm not sure why we don't see that.
Okay.
Yeah, I will have to go back and see, look at the images.
That may have relevance to your toxicity when you do the theranostics part. So that's why I was curious about that.
Yeah, no, you're right. That's a great observation, and I might have it. It's been a while, so this was published 2 years ago, and I haven't. But yeah, that's a good observation, and I think I'll go back and see what's going on there.
And then could you go back to your graphs showing the chemo RAS?
Is that just because of, sorry to interrupt, just because of scaling? Because
I initially thought that, but it looks the same scale.
I
no,
think it
they're
should be
not
the
reduced
same
the same scale. Here
scale.
the scales are
different.
different, 10 and 25.
Yeah,
Yeah,
but
it's different.
And the bone marrow uptake is much more in the patient group probably than in the.
Thank you. Yeah, thank you. Another great observation. I
So
think I'm
but
still in the jet lag.
but if you look
actually
at the
some sort of
splenic uptake,
semi-quantitation will explain you better rather than display of images in different scales.
That's a good observation. Yeah, I think he's right that it's on different scales, and it's probably I just picked it from the raw data and not from the manuscript.
so maybe you even scaled the 3, 60, 240, 24 hours differently as well, and you have just put one scale because the activity seems to be increasing for, if you look at the
No, I think the scales were same at different time intervals, but yeah, amongst normal and myeloma patients, because if there is more uptake in bone marrow in myeloma, the scale will be different. It's kind of sometimes even in the preclinical. So this was done by the residents, the physicians, and I'm not a physician. But even I can tell that it's different in different control groups probably, because if there is more uptake in the bone marrow, it makes sense that the scaling would be different to make
Right.
it.
So Raghu's point, what's happening here is that if you look carefully, I think when the scale was put in, they matched the bone marrow uptake, not recognizing that bone marrow uptake between the normal and abnormal is probably very different. So first of all, that underestimates the bone marrow uptake increase in myeloma patient. Another proof of that is that if you look at the liver uptake, it's also increased in the normal as opposed to the multiple myeloma. So to Raghu's point about the scaling, probably explains that these were normalized to the bone marrow, not recognizing that bone marrow uptake is not the same between the two, and that undermines the intensity of uptake in the liver and spleen in the myeloma patient.
Yeah, but Munir, if you look at the top 3, the liver uptake is changing as well. In the middle, it is lowest. So I think they're changing the scale.
Yeah, it's a good point.
As well, actually, not just all 3.
Some sort of semi-quantitation is needed, like an SUV or
Yeah,
something.
yeah, absolutely.
That's why we are using SUV, mainly because people can change the scale and look everything different.
Yeah.
Even in our clinical work, we are somewhat forced to use the SUV, not to depend on the scaling, because different people use different scales. I have one question, if you guys allow me, is I was more interested in the DARA images, the daratumumab image, and you're using the whole antibody.
Yes.
So how much is the renal, naturally the renal clearance is less, but I don't see much of a blood pool uptake in spite of it being a whole antibody.
So there is not much. This was done at 7 days, 6 days and 7 days. So most of, it's cleared, most of it. And again, the scaling comes in play if there is more signal here, in the tumors, and we don't want to mask to the other uptake to be masked. So it's just that, but there was not much in the blood pool anyway, because this was 7 days. That was the best imaging tumor to background we could get.
And I have another dumb question. Is CD38 is a circulating enzyme?
It's on the cell surface.
But
mostly.
Does it shed and gets into the circulation? Is my question, because that that was one of the problem when we used monoclonal antibodies for lymphoma. The circulating antigens had to be blocked with giving cold antibody.
I don't think so. It's mostly on the cell surface. Yes, it is present on the normal cells as well, but not like in the amount it's present on the tumor cells, but it's mostly on the cell surface. We don't see, I mean, the mechanism is different of daratumumab, it internalizes and everything, but CD38, if we talk about, it's on the cell surface.
I think I was more interested in the blood because CD20 had that problem when we used for lymphoma.
I think it does go on some plasma cells and monocytes in the blood in some altered conditions, but I don't know if it's normally shed.
No, I don't think it's normally shed. It's present on some of the cell surfaces, but not shed in the bloodstream. Not that I'm aware of.
Could you go back to your graphs about the RAST and chemo combined, the first one?
This one?
No, the one before that. Yeah, that
This
one.
one. Yeah.
So here, the bright blue is the chemo RAST, and it actually goes up initially at before 20 days before falling down. And I was curious, is there progression initially before response?
So here we started at day 21.
You started at day.
So the therapy
Okay.
started at day 21. So the idea was to have them all have the same tumor signal, a tumor burden before we start the therapy. So once they were all, once all the groups were on the same scale of tumor, they have the same tumor burden, that's when we started the therapy.
So then if you go to your original without the chemo RAS, it's kind of similar response up to day 40. And then here it increases significantly, whereas in the chemo RAS, the rise it's gradual. It's not stable. I mean, maybe you can call it relatively stable, but it's still trending upwards gradually. So the duration of good response is kind of similar in both chemo RAS and just RAS. If you
but after day 40, like with bortezomib therapy, it's decreasing, right? But in RAS, we see a sudden increase, sudden relapse.
Sudden increase. So I think the chemo is kicking in later on or something.
Yeah, so we want to, so this is all confidential data. The publication is still in progress, like we have submitted it. But this is something we want to see what mechanisms are, responsible for this decrease. Like if bortezomib is doing something, we know that it's very interesting. We worked with some of our collaborators and we saw that ferroptosis might be something, that's been killing the tumors, but it's too soon to say anything. We still are working on finding that. So that's why mechanistic studies are very important. And that's our future direction.
So I suspect that if you do a little more long-term follow-up, it will start rising again, even in this arm. So,
well, we are actually doing some studies for that, and
awesome.
With mice, it's kind of hard. Like you start with n equals 10 or 15, and ultimately you end up getting 4 or 5. You see,
if lucky, yeah.
Yeah, if lucky. So that's the challenge. But we are working on seeing a prolonged response.
What kind of toxicities are you seeing in the mice?
Not really, because the amount we are using, bortezomib, it's all established, and daratumumab, it's the diagnostic dose we are giving. So not really much toxicity. It's just 30 microcuries of zirconium dara we are using.
So what exactly is the zirconium doing to the dara?
Nothing really. It's just that dara is being used to target CD38, and zirconium is attached to dara, and that is the Cherenkov radiation source. So it's basically targeting.
Okay, it's basically or chemosensitizing agent or something like that.
The photosensitizer, yeah, the nanoparticles, the TiO2 TC nanoparticles. So it's all targeted, and we're trying to activate, we're trying different radionuclides, we're trying different photosensitizers to see which works best. So that's something which is being done right now.
Okay, interesting. And ultimately, this should not affect stem cell transplant or CAR T, because that's the ultimate goal. Once you get, durable response and minimal disease, you want to proceed to that finally. And these pre-treatments should not affect eligibility for those definitive treatments. So that
No, that should not affect that. It might, eventually help in that, but it's not going to affect.
Your confidence is refreshing. I like it. We clinicians are always very hesitant to commit to anything because we've been burned in the past, but it's refreshing to see that confidence. So I'm looking forward to your data.
Sure. Thank you.
Any more questions from the audience?
Sama, you had a few questions, right?
Yeah, I have one question for Anchal. So you're showing all this targeted imaging as you started off your talk, you said that FDG PET is considered as the gold standard. Where do you find, or where do you envision FDG in the grand scheme of things regarding multiple myeloma? And right now it's the staple for us as clinical radiologists, that's the thing that we are using.
That's a very good question, Saima. It's like, you can always, we don't have to be like, okay, this is good, this is bad, and we don't have to leave FDG completely. Like, these targeted imaging agents, they can work in synergy with FAT and FDG. There are like, there's data that FDG can show, and then there is some data that targeted imaging agents can show. So they can go in synergy with each other. You don't have to really pick one, is what I see. And these targeted imaging agents can, help the FDG imaging to probably diagnose it better and evaluate the therapy responses, because maybe the limitations that FDG has will be covered by these targeted imaging agents and vice versa. So I see them, to answer your question, I see them going hand, simultaneously with each other.
Yeah, that makes sense. Thank you.
Mm-hmm.
Do we have any more questions? If you have any questions, feel free to put in the chat box, or you can raise your hand and ask the question. We still have some time.
Anytime when a new tracer comes, one of the fear is the specificity. Has there been any study done whether these agents concentrate in an inflammatory condition as well?
That's a good question. I would think there must have been studies done, because these agents are already in clinic. Like daratumumab is in clinic. Even as the imaging agent, there was one group, they showed copper daratumumab in patients, copper 64 daratumumab in patients. So, and BLA4, we have done it with copper 64. So I'm sure there are studies done, and then the dosimetry studies and tox studies have been done, and we have not really seen anything in the inflammatory.
I meant radionuclide imaging and see whether there is concentration in a fracture bone or something like that. Multiple myeloma, one of the important thing is with a lytic lesion, patient bumps into something and gets a fracture, and then FDG becomes hot, and then we are difficult to call whether it was a traumatic fracture versus recurrence of disease. So the same problem, most of the tracers, as we have seen, inflammation behaves almost like malignancy. So in the very early stage itself, to sort it out, Like if one of your rats had a mice had a fracture, then you would know whether there will be concentration there or not.
That's true.
Yeah.
Yeah, that's
Yeah.
true. Only if there was a way, and only if it was not like feel inhuman to do that to a mouse.
Yeah.
But yeah, that's a good point. Actually, yeah, there should.
Yeah,
That's
the
a good.
PSMA
We
and
haven't
the
seen that.
dotatate, all of them, even though we call them specific, they all end up in many inflammatory conditions as well.
Yeah. No, we haven't done any of these studies, but it's worth trying.
Not
I
to put a
agree.
damper on your enthusiasm, but
No, you're right.
that's
And
the-
that's why
that's-
it's always good to present and have these discussions, you see. It's better to have these discussions here.
Yeah, let me tell you the pitfalls we have faced. When we developed Exumin, and we were worried about that also, whether prostatitis would light up. So we did a study on in vitro using WBC and macrophages, and we didn't see any uptake of Exumin in macrophages or WBC. But our study design was flawed because later on in clinical, we saw all the inguinal lymph nodes lit up with Exumin because they're reactive lymph nodes and they would light up. And we knew that it won't be prostate mets, and some we biopsied also, and we found it was not, because the macrophages and WBCs in vitro behave differently without the cytokines in the body. So if you want to repeat something like an in vitro study, make sure you mimic the in vitro environment, same as the in vivo environment, with all the cytokines and all the complements that goes in an infective condition. I'm just telling the mistakes that we have done in the past.
No, absolutely. I appreciate
and
that. You
drawn
sharing.
wrong conclusions. Yeah.
No, I appreciate it. You sharing it. Thank you for your inputs.
Very much. If we don't have any more questions, I would like to thank Dr. Ghai for her time and participation in this webinar. Thank you very much.
Thank you for having me.
We'll see you next month, same time. Take care.
Thank you.
Bye.
Thank you all.
Thank you.
Bye.